neuroimmunologist, also a neurohospitalist at Mass General Brigham, an assistant professor of neurology there with HMS. We get to see a lot of these really rare esoteric cases, but as we were chatting about at the beginning, the standard of care is really dependent on where you trained because we don't really have much formal randomized controlled trials for these cases. So I'm very excited to talk about this with you today. I don't have any relevant disclosures to this talk. So this is what I hope to accomplish today with you all in this time. I really hope to give a nice overview that's concise yet complete about the 5 bulleted conditions that you see below. Talk about the tools that we have at present for a diagnostic approach here, and then really speak about the current state of management. I certainly welcome your questions. There's a lot to cover, and I might not do such a great job of looking at the chat. So if you have a question, please unmute and speak up. And then as you heard, we will have some time at the end for even more formal discussion and perhaps some case review too. So I'll go ahead and get started. So neurosarcoidosis, it's a very fascinating condition that I think we still have a lot more to learn. At its core, what this is neurologic involvement of sarcoidosis. Now, sarcoidosis is this inflammatory condition that can affect really anywhere in the body. When it's involving the neurosystem, this could be the central nervous system or the peripheral or both. And that's what makes it so challenging. The spectrum of where it affects somebody is quite wide and quite variable. There can be cases where somebody just has neurosarcoidosis. So you search and search for evidence of disease elsewhere, and you're really only finding this condition in the nervous system. There are some studies that are mostly retrospective case series and meta-analyses that report on the incidence of this. And about a third of patients who have systemic sarcoidosis will have neurosarcoidosis that then leads to this systemic diagnosis. So sometimes neurosarcoidosis really comes first, and then you do the diagnostic workup, and that's what lends a hand to really finalizing this. But a large majority of patients that have neurosarcoidosis that may not yet have evidence of a systemic pattern of disease, meaning somewhere outside the nervous system, do go on to develop systemic sarcoidosis. And why this is important is because as we move forward as a field to try to better define this condition, we really have to take into consideration all the many organ systems that can be affected and really work with subspecialties that are outside the neurologic subspecialty to be able to say, how do we best treat the patient in front of us and how do we best do this together? I alluded to how complicated the presentation is, which then makes the diagnosis very challenging. And I won't spend too much time on this slide, but it's just a nice brief outline of where sarcoidosis can affect a patient. And what you'll see here is it's pretty much any domain within the CNS or the peripheral nervous system. And most importantly, it's important to take into consideration that about a third of patients with neurosarcoidosis will have more than one nervous system manifestation. And why that's important really will feed into the future slide in terms of the recent consensus guideline publication that we have for how to manage a patient. You want to take a good note as to where sarcoidosis is affecting a patient and how severe at each of these levels to be able to then take that and translate it into the best plan of care. This slide here really highlights a point that I think we really need to come together as a field and keep looking at this. So non-localizable symptoms, what do I mean by that? On the prior slide, you really saw me outline different areas of the central and peripheral nervous system. And in that, sarcoidosis will cause symptoms that tend to be more localizable, so more focal. So for example, a patient might have optic neuritis, right? So their presentation is a visual change. But what about these symptoms of headache, fatigue, cognitive changes, brain fog, even psychiatric mood symptoms? These are symptoms that we all see as clinicians within our patients with neuro-rheumatologic diseases. And the big question is why? And how does this relate to the neuroinflammation that's at hand? And most importantly, how do we assist, aid, and really treat and manage these conditions? This is often the very challenging invisible scar that patients with neuro-rheumatologic conditions carry. And it would be so great to come together from a research perspective and a clinical perspective to really hone in on how do we best either manage this or continue to trend this. And more recently, I've been doing a lot of work with my colleagues at MGP looking at patient-reported outcomes, so for short PROMs. And I really am a strong advocate of integrating PROMs into clinic visits because I feel that having some sort of standardized validated questionnaire could better help us capture how the condition is really impacting a patient beyond what we see on imaging, beyond what we see on our exam. So I do want you to keep this in mind as very important symptoms that aren't as responsive to immunotherapy as something more focal could be, but in some sense, sometimes even more impactful for the patient. So sarcoidosis, how do we diagnose this? So the most important thing to do would be to exclude alternative diagnoses. So the most important not to miss mimicker would be tuberculosis. Sarcoidosis is truly a great mimicker itself, and so on the next slide, I'll show you a large differential diagnoses of other things to exclude. Tuberculosis I highlight because it is similar pathologically. For sarcoidosis on a pathologic sample, you're going to see non-caseating granulomas. And TB, you see caseating granulomas. So it's very important that you really ensure that you work closely with the neuropathologist or the pathologist of whatever organ system you've obtained tissue from to really be sure that what we're seeing matches. Right now, we don't have the most robust serum biomarkers. So you see here three that are listed that are used in clinical practice with variable reliability. The ACE, for example, is something that we learned in our education that's associated with sarcoidosis. But I would highly caution to say that really you should never make or break a diagnosis of sarcoidosis based on the ACE level. It's always nice when you have a case of neurosarcoidosis and you see elevated ACE. It's supportive, but by no way would a negative study negate your diagnosis. Lysozyme is another one that's quite nonspecific, even less specific than ACE. So I would caution you in kind of relying upon that as well, but it is a tool that is sometimes sent. It can be elevated in fungal infections and malignancies and other neuroinflammatory conditions. So again, that's why it's not specific. And lastly, soluble IL-2 receptor. So there's a bit more in the pulmonology literature about this as a biomarker, and it's actually controversial even within pulmonology whether or not it appropriately correlates with treatment response. But at present, it's something that the pulmonologists use. So at times, you might see this sent for diagnostic evaluation for neurosarcoidosis. But my takeaway message here is really none of these are gold standards. They could be supportive, but they should never cancel your suspicion, nor should you rely upon these. In terms of imaging and tissue, I think this is actually the more critical part of the diagnostic algorithm. You really want to seek evidence of pathologic confirmation of sarcoidosis. And most commonly, that'll be in the hilar lymph nodes. And so getting chest imaging, whether it's an X-ray, if the X-ray is negative, I would really urge you to pursue the CT chest. And if you're strongly suspicious and the CT chest isn't overwhelming, I would move on to the PET scan as well, because you really want to find some area of avidity or a lymphadenopathy on a CT chest that you can go and biopsy. And why that's important is because it feeds into the level of diagnostic certainty that we will soon speak about. Spinal fluid is helpful if there's a central nervous system presentation in that it helps support your suspicion that there is neuroinflammation. Most commonly, a patient with neurosarcoidosis involving the central nervous system, they will have lymphocytic pleocytosis on a CSF analysis. Elevated protein may or may not be seen. And in a case series that we've recently put together for neurosarcoid myelitis, about 25% of patients with neurosarcoid myelitis have elevated CSF unique oligoclonal bands. IgG index is another marker, non-specific, but it just shows inflammation. That could also be elevated. There is much research right now looking into improved biomarkers in the CSF. And so what you see on the last bullet here is a list of cytokines and chemokines that recently were published by a collaborative group out of Mayo to say that we saw that these are elevated in patients with neurosarcoidosis. However, they were compared in that study with non-inflammatory controls. So we do need more data to look at these. There are some studies that argue that perhaps a composite of these types of biomarkers is going to be more helpful, and there's unlikely to be one test, at least amongst what we know now to test. It seems less likely that you're going to be able to rely on one CSF marker, but perhaps a composite score of these different variables could be more indicative. So certainly there's more to come there and a lot of research looking at this right now. And lastly, neuroimaging. So we spoke on the previous slide about body imaging, but on this slide, I show a picture of a very classic case of neurosarcoid myelitis in a post-T1 contrast sequence here that you see. And I'll use my mouse and I hope that you'll be able to see it. But what I'm outlining is the pattern of a trident. So this is called a trident sign. Um, Unfortunately, not absolutely specific for neurosarcoidosis, but certainly supportive. And so I think when we look on scans, it's so wonderful if you see this and you're already thinking about neurosarcoidosis. But again, you're essentially trying to find clues to help support you. So when we gather all these clues, how do we actually put it together to have more diagnostic certainty? Well, that's where you have to be very cautious and ensure that you appropriately exclude mimickers. So here I'm just going to let the slide populate. It's a lot, but these are things that you should really keep on your list. Diagnoses that you must exclude before you can rest on neurosarcoidosis. And so you'll see several different infectious etiologies. Cancer, of course, is very important to exclude. As you can see in the picture here in the bottom, this is leptomeningeal neurosarcoidosis. You could see a very similar MRI in someone who has a malignant meningitis or even a fungal meningitis. So you really have to do your due diligence, ensure that you send the appropriate CSF studies if you were to go ahead and do a lumbar puncture here, and be as confident as you can that you've excluded everything else before you can more confidently say neurosarcoidosis. You might be surprised and interested by the fact that I have demyelinating disease on this slide, because the examples I show you here of central nervous system neurosarcoids certainly don't look like demyelinating disease, but there are cases of neurosarcoidosis that have parenchymal T2 flare lesions. So demyelinating disease may be on the differential. So again, you really have to hone your differential according to the phenotype that you might have. But these are possibilities that you want to not miss. So now to probably the most important piece of being able to learn how you're going to diagnose neurosarcoidosis is being very familiar and comfortable with applying these expert consensus guidelines that were led by Dr. Barney Stern and others on this panel back in 2018. What I have highlighted in purple are really the takeaways. So to summarize this very briefly, a definitive case of neurosarcoidosis has biopsy evidence of neurosarcoidosis within the central nervous system. So that's very important, seldomly occurring, right? You can imagine if somebody has neurosarcoid myelitis, how often is it that you're actually doing a spinal cord biopsy? Hopefully not often. But should you have neurologic pathology to show sarcoidosis, you're going to be in this definitive bucket. Your type A definitive neurosarcoidosis, if you have neuropathology as well as histopathology from somewhere outside the nervous system to show that they also have systemic sarcoid. And type B is isolated neurosarcoidosis that's pathology driven. So you have neuropath, but there's no evidence of sarcoid anywhere else from if there was any other site you biopsied outside of the nervous system. So that's the most simplistic way to think about it. From a probable perspective, this is where most cases of neurosarcoidosis fall. Probable neurosarcoidosis is you have the right clinical phenotype, you're doing all the right tests to exclude alternative etiologies, you have histopathology of a non-neurologic site, but you don't have the neuropathology. And this is, again, most common. Possible neurosarcoidosis, I'm glad it exists because there are certainly cases that we know of isolated neurosarcoid, but don't have sarcoid in an area that's actually amenable to biopsy, right? So that's how somebody could potentially be a possible neurosarcoidosis case. Or they have neurosarcoidosis, systemic sarcoidosis, but we don't have histopathology to really prove that. And that's when you fall into possible. Everything clinically fits. You've really done your due diligence and excluded other pathologies, but you just lack any histopathology. I would urge you that although this is among the diagnostic categories, to really be cautious with this patient population and continue to look and reassess their response to treatment and be sure that, this is an appropriate workflow for management. Because if you have a lack of histopathology, it just always leaves a degree of uncertainty. But we certainly acknowledge that this diagnostic classification exists. So how do we treat sarcoidosis? There have not been any RCTs to date for neurosarcoidosis. There certainly have been for pulmonary, and we're really borrowing from these other rheumatologic, pulmonary cardiologists that manage sarcoid elsewhere in the body. The challenges with neurosarcoidosis is that, again, about a third of these patients will have different areas involved. The severity will vary, and because it's fairly rare and so variable, we just haven't yet come together in a very collaborative way to have a robust RCT, and hopefully in the future we can. But what the field still lacks at present to be able to do that is being able to have some sort of measure of outcome of treatment response. There's variable response to treatment when you go and look at MRIs, and for most, contrast enhancement can be helpful to trend, but there are many cases of neurosarcoidosis where clinically they're stabilized or improved, and the contrast enhancement on the neuroimaging still remains. So not even an MRI is a good, really diagnostic tool to trend through time. So first, we need to do more groundwork to develop something we can actually use as an outcome measure, and then hopefully soon we'll be able to move forward with a more standardized approach to studying this. In the interim, many of us who treat neurosarcoidosis have recently come together and published this in Neurology Clinical Practice just earlier this year to provide some consensus guidelines for how do we manage neurosarcoidosis in this area where we lack prospective RCTs. And so the takeaways from the top 6 points are you really need to be attentive to what the phenotype is. And the reason being is we know from anecdotal experience, from retrospective cohorts and case series, multi-institutional collaborative kind of looks here, that there are certain phenotypes that then equal severe functional impairment. So among these are moderate to severe optic neuritis, moderate to severe myelitis, these cases that have these focal deficits that can be very impairing. They do tend to be a bit more aggressive than, let's say, a Bell's palsy from neurosarcoidosis. And this latter phenotype tends to respond very well to steroid monotherapy. So we argue that your initial treatment approach really needs to factor that in. Where is neurosarcoid manifesting and how severe is it? And this really conflicts with the way that the pulmonology world manages sarcoidosis, as there have been their own consensus guidelines that say that we should escalate treatment for all. So you start with steroids and you move to steroid agents thereafter. But we worry that if you started just with corticosteroids and a severe neurosarcoid phenotype, that you may have missed an opportunity to really help these patients. So what we've come together to say and agreed upon with a majority consensus rule here is that some neurosarcoid phenotypes that are known to be more impairing, that are moderate to severe, would actually benefit from corticosteroids and the steroid-sparing agent up front. So that's what's unique about these guidelines. And with time, we hope to be able to more formally study this. The other things here are that you really should think about tapering these steroid-sparing agents and the corticosteroids with time. But unfortunately, we weren't able to come up with very specific delineated timeframes per phenotype because, again, what's the standard of care at one institution or for one provider may vary because we really are just relying upon our collective clinical experience right now and we don't have trials. Here is a figure from this paper that breaks down a little bit more clearly what I was referring to, in that some phenotypes we propose should be treated with what I'm going to term here as inductive approach. An inductive approach is corticosteroids and a TNF alpha inhibitor. So what we know to be the most robust agent to use in neurosarcoidosis. And those are the phenotypes that have higher orange bars here. So for example, symptomatic pachymeningitis. Whereas the ones that have higher blue bars show that we actually think an escalation approach is appropriate. And so an example of that here is a peripheral cranial neuropathy. So again, back to this facial palsy example. And that's because many of those are monophasic, very steroid responsive. So we would think that you wouldn't need to also add a steroid sparing agent up front. And that this is a very, very impactful paper to bring to the field. And I would love to hear your thoughts on this at the end. We still have pieces of care that are essential to really guide others, and we need to work on these. So what we don't know is, how often should we be repeating MRIs? We suggest every 2 to 6 months. How do we balance treatment improvement and toxicities? Corticosteroids, they work very well for neurosarcoidosis, but they come with a lot of toxicity. So how do we really figure that out? How do we know when to start weaning? This is where reassessments, having a biomarker to study is so important. And hopefully with time, we can be more specific here. And certainly what we found was a huge gap of knowledge for how do we manage the peripheral nervous system and neuromuscular manifestations. This is rare within the rare. And so that we weren't able to gain any consensus about how do we manage these phenotypes. So we certainly need more collaborative prospective studies. So in summary, for neurosarcoidosis, there are diagnostic criteria that you should refer to that are highly reliant upon the presence or absence of histopathology. There's a wide clinical spectrum, and importantly, because of that, there's also a wide differential. Keep in mind the phenotype that's in front of you and the severity of a patient's clinical manifestations to be able to drive your treatment approach of neurosarcoidosis. Also, coupled into that is consider where else in the body somebody may have sarcoidosis. So if they have cardiac sarcoidosis and neurosarcoidosis, partner with a cardiologist. Be sure that we're using an approach that works for both systems. And certainly a call to action for more research for this very important condition. So we have a couple more phenotypes and conditions to cover here. So I'm just going to keep going along and we'll do some questions at the end. So rheumatologic pachymeningitis. So many things fall into this. I'm going to focus mostly on idiopathic hypertrophic pachymeningitis or IHP, but I do want to make honorable mentions of, what this is just by definition. It's inflammation of the dura. So you see a nice picture here. Your differential can be informed by the way it looks. So what can cause pachymeningitis are infectious processes, rheumatologic processes, malignancy, or you can have an imaging picture that looks like this because of a spinal fluid leak after a lumbar puncture. And so you really have to think about what's your clinical context here, the patient, what are their symptoms, what are their comorbidities, and then make your diagnostic approach really match and mimic and incorporate all those pieces of your history. What do we know about pachymeningitis? Well, we know how it can present. So most commonly, patients with pachymeningitis will have a headache. And I found that even if you resolve the pachymeningitis, somebody who may not have been someone who frequently had headache now does. So oftentimes you may need more chronic headache management. Depending on where the dural inflammation is, you may have a patient that has cranial neuropathies that localize well, or a general sense of imbalance, particularly if the posterior fossa is affected. You could even have seizures. And again, if we're more posterior fossa, you think about tinnitus as well. The imaging I showed you on the first slide, so you're essentially going to look for a post-contrast T1 enhancement of the dura, and you may see some thickening on the flare sequences. How do we approach this? Again, this is painted by what you've learned by history, but a general outlook, let's say, the field is broad. You think this is a rheumatologic because you've already worked up and excluded some other things by history. It's still important to test the not to miss infectious causes. So I do have tuberculosis, syphilis, Lyme, and HIV up here. Lyme is very prevalent here in the Northeast, so it's almost on all of our diagnostic testing rules. And then from a rheumatologic perspective, these are the tests that I would recommend, especially the ones that are not smaller and italicized. These might be a bit more clinical context influenced, but certainly just generally an ANA and ANCA, IgG4, because IgG4 related disease is very common. Rheumatoid can also present with pachymeningitis, so that's why I have these here. For your spinal fluid, similar to all the diseases that we're going to cover today, is you're looking for evidence of inflammation. So beyond your routine studies, I urge you to always send IgG index and oligoclonal bands. Know that that requires same-day blood to pair to actually see if these values are CSF unique. And then with that, appropriate infectious screenings and malignant screening. So keep that in mind. I think IgG index and bands are underutilized, but often can have the key to inflammation that we might miss with just cell count and protein. Imaging, of course, if you have a brain MRI that's telling, I would consider the cervical and thoracic as well, especially if there's some sort of focal deficit on an exam or by history. And again, look for evidence of a systemic process. Vasculitides are on the differential here. So keep that in mind as you're evaluating a patient. Be sure they have a good ENT exam, CT chest, because neurosarcoid can do this as well. So you really have to take the whole patient into account when you're doing diagnostic studies here. And if you suspect, more likely some sort of iatrogenic cause or a traumatic cause or a CSF leak just idiopathically, I have these studies up here. to keep in mind, just because, if you have a smooth pachymeningitis, it can be just a leak. Whereas if you see the imaging showing more of a granular, bumpy approach on the post T1 contrast, it actually seems to be more commonly tuberculosis or even sarcoid if it just looks a bit more heterogeneous. So again, non-specific, but just supportive imaging clues that you might see. On histopathology, or I should say neuropathology here, what do you see? So this here is a pathology sample from a patient with IHP. And what you see is just some chronic lymphohistiocytic inflammation, but most importantly, no granulomas. So if there were granulomas and they're non-caseating, that moves you from IHP to neurosarcoid associated pachymeningitis. So it's important that the pathologist will look for that too. And of course, also look for any atypical signs that you might see in lymphoma, do some infectious screenings, but this here is what you might see in a patient with IHP. So how do we treat hypertrophic pachymeningitis? Well, the diagnosis is really going to lead that. So let's say that we've excluded infection, we've excluded malignancy, we're really in the inflammatory rheumatologic bucket. Corticosteroids, you're going to hear me say this again and again, first line for pretty much all of these conditions. Most commonly, you're going to give a high dose IV methylprednisolone, a gram, for about 3 to 5 days. And then after that, followed by a taper. And that's where it's variable by practice. I personally then start most patients with oral pred 60 milligrams, and then I try to taper from there, depending on their dose response. Maybe I'll hold them at 60 for a week or two, and then try to decrease by 10. And if that's unsuccessful, I'll go slower. But the goal is really to manage, to treat, but to also minimize toxicity. So you have to take into account all the side effects the patient's experiencing, what's their premorbid infectious risk. You really have to individualize your plan for everyone. So there's not a one size fits all. There are many cases where you may need a steroid-sparing agent. So this, again, relies upon what you think the cause might be, but even in severe idiopathic hypertrophic pachymeningitis, I've had patients fail corticosteroid monotherapy, and we ultimately place them on rituximab, which is borrowed from the IgG4-related disease literature. If it's mild, I've had some success with mycophenolate and corticosteroids, but it really, again, depends on your treatment response. And this is where serial neuroimaging is very important, as well as your exam. But I can say that, from experience, I've had patients with IgG4-related disease where the pachymeningeal inflammation just remains stagnant. We kept giving them rituximab every 6 months, and then on one of the every 6 months MRIs, magically we started to see an improvement. So don't be discouraged that you see stability on imaging. You keep treating as long as the patient's tolerating and you're ensured that you've ruled out the alternative causes, and then potentially you may see some response, but not all. For some, stability is a good outcome, and and I think that's the difficult challenge here. So I'm now going to move on to Neuro-Behcet's. The rest of these conditions, we spent a lot of time on neurosarcoid up front because I think there's a lot more in the literature there, but this even speaks to a rare condition that we're still learning about. Behcet's systemically, rheumatology has done a great job really widening the treatment plan here and getting a handle and treating, but Neuro-Behcet's remains a very rare manifestation of the systemic disease. When it is present, it can be very serious. And the problem is this, different from the prior two, is that there also can be neurovascular complications because Behcet's at large can cause this hypercoagulability. And so a patient may present with a new venous sinus thrombosis as their manifestation of Neuro-Behcet's. Or you may see something that's a bit more classic for neuroinflammation, like I'm showing you here. This is almost pathognomonic for Neuro-Behcet's when you see this kind of midbrain predilection of flare signal change. How a patient might present clinically with an MRI like this is they may be encephalopathic or have other neuropsychiatric changes on top of any focal deficits that localize to where the inflammation is in the brainstem. And by that, more specifically cranial neuropathies. You can certainly have a myelopathy from Neuro-Behcet's as well, or just generally speaking, intracranial hypertension with or without a clot. So if you have a patient with Behcet's, and they're having neuro symptoms, really be mindful of all these possible pathologies. So in addition to a brain MRI, pursue some venous imaging as well. how do you make the diagnosis of Neuro-Behcet's? Again, you're really looking for a systemic disease. This is one where, at least in my experience in my reading and talking to rheumatologists, I've never met yet a patient or heard of a patient that could have isolated Neuro-Behcet's. These patients have systemic disease and then may have Neuro-Behcet's. Of course, they may not know that there is systemic disease at time of their neuropresentation, but more commonly, the Behcet's is known, and then we develop neurologic symptoms. So the presentation will vary again on where the pathology is and what the pathology is. We spoke a bit about this predilection for the brainstem and the thalamus, but you can have a meningoencephalitis, you can have clots like we talked about. And interestingly, there are some possible chronic changes with Neuro-Behcet's. Even without a very striking neuroinflammatory acute event, you may notice on serial MRIs some atrophy. And this is what's extremely interesting, and I think really just shows a hole in our knowledge for neuroinflammation is this kind of chronic inflammation process that we more recently have started talking about for multiple sclerosis. It seems that this also might be at play in these other neuroinflammatory conditions with this as an example. So certainly you need to look more into that. We lack a very specific biomarker for Neuro-Behcet's, but things that you might see are, again, general signs of inflammation in the CSF. So similar to the prior studies, send your routine, send your IgG, send your bands, really look for any clues of inflammations. And I think what's important to highlight is that the haplotype B51, although it's a genetic risk factor for Behcet's and can be used to help diagnostically kind of give evidence here, it's not actually thought to be the gold standard. So keep that in mind. You may not find this in a patient who has Neuro-Behcet's, and I think that's kind of underappreciated. How do we treat Neuro-Behcet's? I would say because rheumatology often has already put this patient on systemic management by the time there's a Neuro-Behcet's, certainly partner with rheumatology. I can't emphasize that enough. They use similarly corticosteroids first line, but often with the steroids sparing up front because Neuro-Behcet's again can cause splenic infarcts and very profound deficits systemically. And so I would say that often Neuro-Behcet's is treated a bit more aggressively up front. And particularly when there's a progressive or relapsing phenotype, that's when patients are further escalated to treatments here, as well as some that I don't show, like golimumab, for example, or other TNFs. So there, you really need to partner. Ancillary services, I think, are really important. We haven't really spoken much about this in the prior two conditions, but the reason I highlight this here is in Neuro-Behcet's, about a third of patients with Behcet's without any known neurologic manifestation that was clearly diagnosed may show some cognitive dysfunction. And this is particularly a bit more common for men with Behcet's. And so I think, even if it's not apparent that they may have an abnormal brain MRI, I would urge you to really ensure that neuropsych testing is performed so that way we best know how to support our patients and we know where there may be difficulties. And what's been seen in prior studies is that patients with Neuro-Behcet's or even just systemic Behcet's may struggle some with short and long-term memory as well as attention. And in Neuro-Behcet's particularly, there's also a visual spatial component to this. So really important and underappreciated because sometimes if it's a mild deficit, patients may not even recognize that they're struggling with these things. But if we use our tools and our other ancillary services like neuropsych and cognitive therapy and occupational therapy, we can really help improve somebody's state of being. And so I really urge, a full look at the patient cognitively and psychiatrically, particularly in this disease. But I think again, that holds true for all neurorheumatologic conditions, taking us back to one of my earlier slides where I talked about these non-localizable symptoms of brain fog, for example, or cognitive change. I think there's a lot there that we don't yet have the tools to measure, but the patients are certainly experiencing. So neuro-sjogren's, the final two conditions before we move on to discussion and cases are neuro-sjogren's and neuro-lupus. And the reason I want to really spend some time talking about these is, again, it's very complicated. Sjogren's and lupus as their own rheumatologic entities are very challenging to diagnose because similarly, there's not always a gold standard. For Sjogren's, we have a little bit more by way of diagnostic tools because patients can have certain salivary or lip gland biopsies that really help confirm and support the diagnosis. But patients with lupus, it's even more challenging. We have the ANA, we have complement, C3, C4, double-strand DNA, and anti-Smith, and all these tests that we can send. But really, none of them pair all that well when there's a neurologic manifestation. So, focusing on neuro-sjogren's at the moment, how can this present? So, like neurosarcoid, it can involve the central or the peripheral or both. But I would say commonly the peripheral nervous system is seen a bit more often. And so the phenotypes that can be seen here are very challenging, very refractory to treatment. And often I think that goes in part with the fact that for patients with systemic Sjogren's, we really don't have a delineated treatment protocol to apply. So you may meet a patient who has just mild peripheral neuropathy or someone that's affected so severely that they actually have a sensory ganglionopathy. A small fiber neuropathy is also part of this bucket, and kind of related to that comes the dysautonomia. There are types of cerebellar degenerative phenotypes that are attributable to Sjogren's as well. So do keep that in mind. If a patient's a bit ataxic or dysmetric, pursue a brain MRI. It may be normal the first time, and I want to really emphasize that. Patients with autoimmune cerebellar changes on their first eval may actually have normal brain MRIs. But on serial repeat brain MRIs, that's when you may start to notice the cerebellar atrophy. So do keep that in mind. So again, partnering with rheumatology is key. We do have, as I mentioned before, some tests to really measure dryness by tear production, saliva production. There are some biopsies, but neurologically, the arsenal of testing that you're going to pursue is really going to be dependent upon what the symptom is that the patient has. So is this more of a concern for a large fiber neuropathy? Go for the EMG. Do we think it's a small fiber dysautonomia? That's when you may pursue skin biopsy or autonomic studies. Autonomic studies are actually really hard to come by. Even within our own system, the wait time could be greater than a year. And so I think I would actually urge, although we have some of these tools, really rely on your clinical assessment. Do a really great exam, take a really good history. Because, for example, in a skin biopsy, it's a biopsy. And so if you're really worried that somebody has small fiber neuropathy or dysautonomia, I think it's appropriate to move to manage appropriately their symptoms, even in lieu of these, diagnostic study results. So do not rely on them 100% wholeheartedly because the patient may go many, many months without being able to have these tests completed and they're struggling with the symptoms. The symptoms really are mostly symptomatically supported, but when there are severe phenotypes that I list here as the sensory ganglionopathy, for example, or cerebellar ataxia, those two particularly, I would say that most, if not everyone in the field would agree with me that we should be aggressive with immunotherapy because of the destructive and progressive nature of these phenotypes. And so what that often looks like is corticosteroids, IVIG, with or without cyclophosphamide or rituximab, dependent upon your practice and who you trained with. You might have a preference for one over the other, but we really have to be aggressive with the sensory ganglionopathies and the cerebellar degenerative phenotypes from Sjogren's because they worsen so much. And I will say a very important not to miss differential diagnoses for these top two phenotypes is anti-Hu. So even if you have a patient that has Sjogren's and now you're worried they have a sensory ganglionopathy, do a very thorough evaluation for malignancy. Really look for these gynecologic cancers, which are commonly associated, but even more broadly, pursue a PET scan, get a gonadal ultrasound, and then, send your autoimmune panels to look for autoantibodies of the Hu and the CSF or the blood. It is one of those autoantibodies that might be falsely negative in the serum, but positive in the CSF. So for a patient with this phenotype, I do think a lumbar puncture is indicated. For the small fiber neuropathy and dysautonomia presentations of Sjogren's, I think we really need to do more research here. Historically, some patients have applied or have used IVIG for these phenotypes, and really the results from my own practice and from the literature are very, very mixed. And I think we just need formal studies to really look at autoimmune dysautonomia and see if there's any role for any of our immunomodulation. But unfortunately, these phenotypes seem to be highly reliant upon conservative management only. So things like midodrine, for example, for the dysautonomia or neuropathic medication for small fiber neuropathy. I seldom apply IVIG in these cases. So lastly, before we break for a discussion in cases, I'll speak a bit about neurolupus. I think neurolupus as a whole is quite a loaded term because all of the phenotypes that can be within neurolupus will be under this term. So technically, by definition, neuropsychiatric SLE actually encompasses all of these, but clinically we don't use that term in this way. So I have split it up here to separate it out from other clinical manifestations that can be consequence from active lupus. Similar to Behcet's, you would expect active lupus systemically before a patient develops a neurolupus phenotype. The only exception to that would be perhaps patients have controlled systemic lupus, but they're struggling with these non-localizable symptoms of headache or brain fog or cognitive dysfunction. Certainly, we see that often. But I would be very hesitant to say that a patient with controlled systemic disease will have seizures because of their lupus. I would not expect that. I would, really want to see some evidence of CSF inflammation to be able to blame the new neurologic manifestation that's that focal or localizable on the systemic disease. Here is a chart that shows what neuropsychiatric lupus actually is. So again, it's a bit of a misnomer, right? Because you would never really clinically bucket cranial neuropathies into this, but this is from the American College of Rheumatology, and when this term is used, it can really apply to any of these CNS or peripheral manifestations. And you see a wide spectrum here, from stroke to movement disorders to confusion to psychosis to myasthenia. It's really broad. So essentially, I think we just need better evidence to say, how and why would an active systemic lupus be able to then lead to such neuroinflammation in these ways? And I think that's a really fascinating field that certainly we need to spend more time looking into. Similar to neurosarcoid, the management of neurolupus is again phenotype driven. So by definition, if somebody has active lupus and then they seem to have strokes that were relating to their lupus, it's technically a lupus vasculopathy and not a vasculitis. When you look at all the neuropathology, what you see is small vessel involvement, some immune complex deposition, inflammatory cytokines, but it's rarely fully destructive like an ABRA, for example. And so really the term is a lupus vasculopathy. Patients with this will have many risk factors related to their lupus. So certainly lupus vasculopathy will have these inflammatory cytokines and complex deposition in the CNS blood vessels, but you can have strokes in the setting of active lupus because there's uncontrolled hypertension, which may be resultant from very poor renal function, or they have a positive antiphospholipid antibody and syndrome and they're having hypocoagulability from that. So we have to think about a patient with strokes and lupus in two ways. Tackling their stroke prevention like we would for any other patient, managing their blood pressure, putting them on antiplatelets, appropriately managing if they have antiphospholipid syndrome, but then also think about their inflammation and how do we really put a lid on that and make sure that that's not driving the strokes also. So there's a twofold approach there. In neuropsychiatric changes in a patient with active lupus, the role of empiric treatment is really unclear. I would argue that if patients have a subacute neuropsychiatric decline, then in my own practice, and I think most would agree, that would be an appropriate treatment to patient to treat as if they had an autoimmune encephalitis. They have a subacute neuropsychiatric decline. Their lupus is active, so maybe we'll blame it on that and we'll still search for a cancer. But if we come up short and we don't have any autoantibodies, it might be named lupus-associated encephalitis, right? And for that, even though lupus is part of that diagnostic name, you still need to treat the inflammation. And so I would say there are phenotypes where it's clear that that's indicated. I think what's really hard and challenging is that when there's brain fog or more non-specific chronic gradual changes in cognition, that's where the role of treatment is really unclear. That's where neuropsych testing is very helpful. And I think right now practice is really managing the symptoms, but we certainly need more studies to say, what do we do? How do we manage when there's more of a cognitive chronic problem that's not so subacute and drastic? How do we help support these patients? So that completes kind of my overview of the 5 different conditions here. I want to open up now to questions so we can have some discussion, and then I do have some clinical cases to help prompt our discussion as well, but maybe I'll break for a moment and see if there are any questions anybody has.
I want to say thank you so much for a great presentation.